morning,
You can still see?
Professor Krisht and your team in Little Rock and all colleagues in United States. I appreciate very much the occasion to give a lecture, electronic lecture through internet to you, to tell a little from my experiences about the intracranial and a little about the spinal AVMs. I mainly operated the cases at the University Hospital Zurich and then in Little Rock, then in some areas as a visiting invited neurosurgeon, some few in other countries. The vascular organ, it is an organ. The differentiation between arteries, capillaries, and veins, the interpretation of systemic cardiopulmonary and distinct central nervous system hemodynamics, clarification of the biology of the blood and the lymph organs, these are other organs, elucidation of vasomotoric system and of the enigmatic blood pressure still is not well controlled, required centuries of intense investigation to achieve effective knowledge. The history of medicine presents us an impressive cooperative, but also a controversial evolution of concepts and convictions related to the vascular organ and unique functions. The vascular system in general and the neurovascular system in particular disclose anatomic, embryonic, histologic, genetic, physiologic, pathologic, medical, and surgical fascinating aspects. For young colleagues, each area is still open to discover new aspects. The neurovascular organ evolves into phylogenetic, ontogenic, infantile, adult, and elder age stages, stepwise. And the transformation of the vascular system is unique. We will show this. It is a heteromorphic and heterofunctional open system with a unique capacity to fluctuate and adapt according to focal and regional requirements of blood supplement. The history is very important. I recommend all of young colleagues to go a little into the history, because the deeper we go and seriously study what's happening, then we have a much more view for the future. And then it took long time until in the 19th century was discovered on the 20th century a paper in Marketplace on Egyptian medicine. It's between 17 to 25 centuries before. And then Breasted bought these papers and then give to the museums, and later on it was deciphered. And you see here how in old Egypt written the name of brain and gyri, even membrane, and CSF. I didn't have a chance to study these things myself. I did like I would see also the vessel, how they documented in hieroglyph. But there is an excellent paper from Professor Wilkins, American neurosurgeon, in Journal Neurosurgery, 1964. You can see page 240 and 244. He gives a short information, but very important. And the left side here, we see a statue. There is a famous Imhotep. He was some 2,000 years before Hippocrates, a unique person as medicine man and statesman, and he is the founder of the Egyptian medicine. We have to relate to this because the Egyptian was originating later on the Mesopotamia and then finally in Greece. Now, in Egypt, these two Greek scientists, we can call them as a fathers of neuroanatomy and neuroanatomy also. Herophilos was born here in Istanbul and went to Egypt to new built city Alexandria. We know from history Alexander the Great made a unique conquering to Near East, to Central Asia, and built some 10 cities, Alexander cities. And then in Egypt, he was very impressed from Egypt culture, and he built Alexandria. And these two gentlemen started to study their anatomy, and they had a chance to see also how the experts in Memphis nearby, how to prepare the mummified prepare the mummies, yes. It's correct, and mummy, yeah. And interesting, they studied all the organs and saved all organs of body, but the brain was destroyed. Funny. They entered transnasal and destroyed. It's said. Now, Herophilos studied the brain, vein especially, so we have his name now in Torcula Herophili, where the superior sinus and the transverse sinus connect. And also the Erasistratus was an expert on vessels and also in the arteries and veins, and then sensoric and motoric nerves. They studied all this. They gave the first steps of the neuroanatomy. I don't like to stay longer here because I have to tell you more. Being visiting Mexico, and I operated also there 2 cases, and in the hospital of pediatric hospital. In the entrance of the large hall, some 3 meter high or the more, is a fresco on the wall showing entire history of the vascular organ and diagnosis and therapy. And all involved people are also Chinese, and then old Indian and old Native Americans are presented. Very interesting picture. If you go to Mexico City, you can see there, and the Hippocrates is here, the Galen is also here, all others. Interesting is Ibn al-Nafis, He was born in Damascus and was active in Cairo. He discovered the pulmonary blood circulation, coronary arteries, metabolism, and he described very well how the blood circulation long in the bronchus happens. He wrote his books around 13th century, but it was translated in Latin and went to Venice and from there to Europe. And Servetus took this knowledge and put it in a small paragraph. To begin, in Western world, modern neuroanatomy is Vesalius. He is from Dutch and came to Italy and in Bologna, Padua, Pisa, Venice, he was working. He died in age of 50, unfortunately, by a trip to Near East. But he made it excellent systematic studies, and he had an excellent artist to draw, but he made it. In 1543, he published his famous book in Basel. In Basel, there have been several experts for pictured books. And so we see first time here the brain well and all the brain arteries and veins. Vesalius was studying the Galen's anatomy, but was found he was stimulated, but he found some 200 wrong information. If we look to this picture of this south arteries and veins, also there is some confusion is there. It is not precise. But he was at the beginning, and he stimulated. He's not alone. Around him, before and after him, then it started hundreds or more anatomists. Important as far as the English scientist William Harvey went to Italy, and he learned in Bologna from Italian anatomists a little more about the vessel system, and he got the excellent concept how the blood and body circulate. He published 1628 his famous book. But some authors in Europe said this is nonsense. This is everything is wrong. This is normal. This contradictory concepts. Thomas Willis is another great scientist, surgeon. He had a chance to dissect and study, and he gave an excellent book about the brain arterial, but also the brain cortex and the subcortical areas and the form nuclei. He realized the special anatomy and gave an excellent picture about the circulus cerebri, the arteries at the base of the brain, how they connect. So it's called now circulus of Willis. The picture was drawn by famous great English architect Wren. In same time period, we have a contribution from Malpighi. He discovered the capillaries between arteries and veins. And then it is not well known. Webfer is a Swiss scientist and practicing doctor. He wrote 1685 or 58, 58, and in this some voluminous book in Latin, it described very well circle of village, but there's no picture. He discussed the stroke and very precisely the TIA, transit ischemic attacks, and the full stroke. These four gentlemen gave the puzzle column for our neurovascular system. A historical picture made from great English architect Bren, how it looked, how he saw the brain and the spinal basilar artery and the circle of Venus. And later on, this is now drawing by other artists or anatomically precisely. Next slide, please. Now, the interest was born, and we see in 17th century, Frederick Roche, another Dutch scientist, he found that technique to inject wax, fluid wax in the arteries, and gave some colors, and it is unique. You can see in the middle picture, perfect, everything is there. Oh, he made this, incredible. And he was giving lecture in the entire Europe, and the people have been excited. Also, we are excited. Look, this is fantastic. And then another century is the 18th century, but in Italy it was an old tradition. The wealthy people did like to have what if a church that made from wax the figure. And Zumbo is the leading man, and then the Suzuni, 100 years later, here. If you are in Florence, visit the Museum La Specula. In 4 or 5 rooms, there are exhibited some 2,000 wax figures. They are made by wax. And you have the feeling, oh, they are living, so such a vital, animated figures. At that time, it was the only chance. There was no photography, no films and videos. And this was a good teaching stuff. And he made 2,000 entire body. And I was very impressed to see also the spinal cord vascularization. So perfect, so incredible. And you see here, on the brain, you see all the arteries, there is a better brain. But somebody really, the TV system should go to Florence, make more pictures. And he was, Suzini got helped by another scientist, neuroanatomist, Fontana. Fontana was very informed, and he made the section, and then he made the wax figures. And 2000 was given to the University of Vienna in Austria, and Montpellier in France, and one in New Orleans. The pieces in Vienna and Montpellier are still intact, also in Florence, but in New Orleans they disappeared. Another recommendation for you is this publication from Marin Padilla. I met him on a surgical meeting and was impressed how he presented embryology, ontology of the entire brain. And he showed us how the meningeal system and the brain tissue in the vessel, synchronical developed this, and I asked him, please give this a paper for us, a chapter. It is now in the volume 3A, micro neurosurgery, AVMs. You can read some 20 pages and excellent pictures. And you are at home. I'm surprised by discussion or by papers. It's not well realized, this synchronical development of meningeal system, parenchymal system, and vascular system, and CSF system. Here, in these two books, two volumes. In the first one, I gave the anatomy. In the second one, B is the surgical experiences. 414 cases at that time. First book, A, was published 1984, the other one 87. In the first book is Marin Patila's embryology. And I would say it should be well discussed, and it was appreciated for some colleagues. They said, oh, they use the books if they operate the AVM. But I did like to present it again, discussion in other journals. This is over history. Now, if I am done, maybe they will start to study these things. There are really information. It is not my own idea alone. Or I had around me in Zurich excellent neuroanatomists, in neurologists, in neuroradiologists, and then visiting colleagues and discussing with them, and discussing when I visit also other countries, and so hundreds of colleagues and discuss. It is our time period between 1953 to 2020. Who is this man? He is a great French general surgeon, A.N.I. He operated in May 1889. First case, 15-year-old boy, had a left-sided Jackson epilepsy. And now Jackson, first time described, if somebody has only this side shaking of the extremities, one side, on the opposite side, maybe a tumor. If you may believe or not, in the volume 3A, I put a list from 30 cases operated from general surgeon. They thought it is a tumor. It turned out to be AVM. And it's interesting. Some could remove the AVM or ligated some vessels, but he made a removal of the central area. And you should read his article and very in French, very important. Now, it is also in the pathology discussed. Great Austrian pathologist Rokitansky, in 1851 he published a 6-volume pathology. And he was expert in carcinoma of liver, and he believed there are tumors. And John Bell in England, he separated, differentiated some 6-7 type of vascular malformation. And then Virchow, 1851, gives credit to Bell also. He studied micro AVMs and said dilatation of small vessel in the erected tumors was before said, but he said it is better to say them aneurysm arteriovenosum. So it's the term is still present. We can differentiate also some 6, 7 type of malformation. I like to mention also William Hunter, English gynecologist and general surgeon, and then he gave the term of abnormal anastomosis between arteries and veins, erectile tumors. So the term for anastomosis comes from Hunter. His brother John Hunter was also a genial person. He taught himself by his brother's laboratory, studied all animals, and he also found arterial collaterals. The term. He operated aneurysm of the popltea and he ligated the femoral artery. So in Western literature or Western world, neurosurgical, it is well known is Hunter ligature. But I will tell you it was earlier. Now, the entire development was a great breakthrough by this German physicist William Röntgen. 1895, he discovered. He was behind it, but like Madame Curie, they carried the radioactive structures element in their pockets. He discovered it in 1895. And we see here the first AVM in Monizina, Monizina limb complication. So it was great. Harvey Cushing, as a young neurosurgeon in Johns Hopkins Hospital, he insisted to have an X-ray operate. They both, and it happened. A young lady was shot from behind with gun and was paralyzed. And he made an X-ray, Röntgen ray, and then there was a projectile in the cervical spine. He operated the lady and she improved. So Cushing, as a general surgeon, later introduced legally the neurosurgery separated, and he introduced the radiology in neurosurgery. He was the pioneer on this. But there are other pioneers. Oppenheim is a neurologist, but he supported the German neurosurgeon Krause very, very much. Then you have Professor Schiller in Vienna. He studied especially head bones, precisely wrote a nice book in describing all in detail. He's one of the pioneers. He left in Australia, went to Australia. Walter Dundee in Johns Hopkins Hospital. Another very great neurosurgeon in USA. He came to the idea because he saw one patient with an injury of the intestine. It was the air in the abdomen. He got immediately the idea, hey, we can use this for ventriculography. So he introduced Systeno, air, cysternography and ventriculography. Later on, cigar in French use another material. In Lysholm, in Sweden, or better X-ray operates. And in Portugal, Hegemonis as neurologist and Dalima neurosurgeon, they work together, and one is on a meeting in Paris saw angiography of the extremities. And they came to the idea we must do it cerebral angiography. And he started to use this for first in dogs, and then later he had help by the Dalima, as a neurosurgeon. He made all the angiograms. And so it started 1930s, the cranial angiography. Is the history. Here, we know now a lot about the AVM because we have now the possibility to make the angiography study in different phases. And they can be in dural, in skin, in muscle, bone, dura, in systemic area, and then clear cortex, subcortex, and then deeper area in the ventricle, and also in the orbita. It's a unique disease. It attacks usually one segment of the brain and spinal cord, but it can be so combined. They are very rare. We saw only 2 cases in Zurich. This time extended. These malformation can make a headaches or seizure or mental deterioration slowly in all bleedings. But then if there is a bleeding, the people are alarmed to give an indication for surgery. We have to pay attention. The perfusion of the blood flow in brain to a certain pressure in the veins. In the veins, this pressure goes down. But if we have a direct connection between arteries and veins, there is a high pressure in the vein. As a consequence, you see on this lower picture, the venous system make it stenotic, especially in straight sinus, because it is fixed in the dura. If we see the narrowing, we have to do something. Here you see a patient at the left side, right side. We see from top. I like to see right. Here, the first picture, right side, white color, as you know, the blood in the middle, amygdala, hippocampal area, medial-basal temporal, and AVM. And Mr. Roth, our artist, made a beautiful picture. I appreciate very much the work of the scientific artist because on picture it can be excellent, even on MRI with 20, 30 modalities. There are two-dimensional. But the artists, they bring the vital condition. They animate it we can see here almost how the blood flow go around. The knowledge of artist and his talent add something. But in an MRI or CT and all other pictures and the angiography is two-dimensional. I will talk this later. In these cases, we can operate. We can remove the malformation and also the blood and the tissue which impregnated from blood, because brain doesn't like blood, make seizure. We have to remove, in this case it was also seizure. It's never breathing. You see, I've mixed a little the picture, sorry. This was the angiography of this medial-basal temporal lesion in the basilar vein and entering into the galenic is dilated because straight sinus, you see, it is not full color. So it is a stenotic hint. It is narrowed. Here, postoperative. Sorry, I put wrong. Postoperative scan. It's intact now. Coming back, the AVMs, they can be localized in neopallial area, in archie, in paleopallial area, in the basal ganglia, in the encephalon, mesencephalon, down. Here, this was combined by Valavanis. You can see different type, one in the frontal, superfrontal, in pyramidal shape, and here in the middle frontal area, and then here in the temporal area, in paleopallial, and we see here medial-basal temporal, and here the cingulate area, and here the insular area. Historically, we have to give a great respect to Professor Herbert Oliver Krona in Stockholm, and he made excellent aneurysm and AVM surgery, tumor surgery, especially schwannoma surgery, and described very well. And here is how he removed the malformation in a circular approach. He published 1957 his experiences, and on a meeting I made myself this photography. Left side you see Professor Tennis, chairman in Bonn, Germany, and Oliver Corona. He published, Tennis published also 1959 his book. But pay attention. Oliver Corona saw 1923, 35, in 12 years, 18 cases, operated 5. But 47 to 54, he operated from 64, 80%. This is advanced. You have to read the original result from Oliver Kroner. Here is my teacher and chairman of neurosurgery in Zurich. He founded the neurosurgery in Zurich, 1936, was chairman until 73. Very strong character, very disciplined, but correct. And I assisted him in many surgeries. He operated altogether 188 AVMs. It is published partially, but not completely. And I was planning to do it, but it remained still. He was an excellent surgeon. He operated mostly in the polar area, temporal, occipital, frontal, periparietal areas. And he knows his own limits. He said, I can do it or I cannot do it. This is very essential. And if he decided to do it, he took time and he was patientful, very meticulous and disciplined. I entered the neurosurgery in 1953, and next day I had to go to radiology. There was no radiologist until 1978. Valavans came in 1978. And I had to perform transcutaneous carotid vertebral and orbital angiographies. And I had a great number of patients because we didn't have a CT and MRI. Postoperative control, if there was some unclear situation, we made angiography. Or if the patient came in, first apparatus was electroencephalography. If there was any clear sign, left or right side, okay, we made the ipsilateral angiography. But sometimes it was not clear what's here. Papillary edema and the patient has seizures, okay. We didn't like to make a ventriculography, was made sometime, but angiography first. So we did a great number. And now, for the colleagues, the first blue books concerns the vertebral basilar, more infratentorial, arterial, and venous system, all the variation is German. The second book is entire carotid and vertebral. And it is good. You should see these books because I spent really some 10 years to study from thousands of angiograms the variations, individual variation of each arteries. But I had to give a great respect to the publication of Newton on pot. I found they made a volume 4 and an excellent publication of angiographies. Newton spent for a while with us in Zurich, and so we get a good friend. Now, here in Zurich, we had a special disc operate. Dr. Kreinbill brought this from London, so by artists, you can we made a serial angiographic with change position of the X-ray camera, 5 degree, and another series. On our series have been always 6. Beginning of the arterial phase, then full arterial phase, capillary, late capillary, and early venous, full venous, and the sinus. And we spend every afternoon 1 hour with Dr. Kreinbill and studied here. There are right and left 2 serial picture, starting with the early arterial and later. And here in the middle you see double mirror, and you can open the axis a little related to your eye distances and move forwards, backwards. You can study frontal, central, and then parietal, occipital areas. Beautifully. It is, you can have it even on, they show now on television, houses and an inside apartment, etc. But it is not three-dimensional. If you have this three-dimensional system, you have the feeling you are sitting in the brain. You are in the room. Then you got relation. It's not a foreign object. It is like your own body, the whole room. So this was our way, and I am very unhappy. This is also not generalized. Nobody use this technique, this stereo angiography and study. And I may say, I am still missing this three-dimensional angiography, and we don't have any CT and MRI three-dimensional. So I'm missing this. It is not the same quality. Now, what is wrong? Our pupillary distance is in average 60 millimeter. And then by magnifying glasses, it is 40 millimeter. What you here see is behind the objective of the operating microscope, there are two small eyes. These are 16 millimeter apart. So it gives us the stereo view. Here, there's the trick. I may apologize. I forget to put this in the publication. I forget to put this picture. This is essential part. Why we, and also we are accustomed to see binocular or stereoscopic. If we are looking quietly, it is a stereo, three-dimensional. But if I move my eye, it started to be four-dimensional. And then if I move the body, it's much more four-dimensional. If somebody move in the room, it's almost five-dimensional. So we live normal life always with 4, 5 dimensions. And then this modern world fix us in books, in city, in MRI, and on the TV, and on the. And we made also videos, operations, three-dimensional. So you see on your backside the two boxes, they are projectors for the stereo pictures. I have some 3,000 videos in depot to show how to operate, and you can see three-dimensional. Okay. Now, also we have to have not only two forceps. There are some 30 forceps. It could be more, but also this is enough. Different tip size and length. We on surface, you see like here, and then longer. You go deeper and deeper and deeper, and you need longer. We have forceps 13 centimeter long, and this is very essential. And then, sorry, I must go back one here. And then I developed this, I asked, and they made it this hydraulic chair. I can move up and down, and we have a nice wheels, and then armrest. Mobile armrest, hydraulic, turn 360 degree. So your arms are stable, forearms and hands. You can stay in the air 10 minutes, 15 minutes, but then you will have a unprecise movement. You have to stabilize the arm to be precise. This is my message. And it was not possible in Zurich. The company did not make a continued to make it better. And now in Istanbul, somebody in the company made it. It's available now. Another important stuff for surgery are these sponges. These are very special sponges in soft, different size. I may use really 100, 200 pieces in one surgery. And if I use, and the nurse give me a new one. Now, coming to the surgery of AVM. I learned also from publication for Oliver Corona on tennis and watching Dr. Cranville. We can eliminate the superficial arteries, they are dilated, and the deep arteries from the base, they are small. Now, my main critic to the endovascular approach to the interventional neuroradiologist, if they eliminate all these cortical branches on surface, and then the blood flow is reduced. But if they are not eliminated, the feeder from perforator, there is a still arteriovenous connection, and they get dilated. And it is extremely difficult if these are occluded and some other here around, and you approach, it is very difficult to coagulate them. And we developed special small clips for this, temporary clips. Now, you see the AVM, pyramidal shape, segmental, from the superior frontal area, going to outer removal. And here on MRI, how it looks, pay attention, the curved angiography, the straight sinus is stenotic, and all they look so really impressive, large AVM. They are not that much large. They are dilated veins. They cannot they don't have a good flow because there's a stenotic straight sinus. You can see almost in at least in 70% of AVMs are straight sinus stenotic. Here after removal, here we didn't remove any normal tissue. We removed just the ill area. Another case, important. I showed these cases, you know why? Pay attention. I did know there is a one large vein artery coming in. I removed this part. And then you see on this picture, on the upper corner, the pyramidal shaped AVM removed, but the deep perforator is still there. I didn't know this, but I didn't dare to enter in this area, that double the internal capsule area. So I told the family, sorry, there is a rest. But I know one colleague, he could help. And then I recommended to go to Zurich, and Professor Valavan will close this. It happened that I was also in Zurich. From Little Rock, I went there. It took not more than half an hour until he brought the catheter in and injected and gone. See, it's clean. So the patient is in excellent condition. But so this is the combined work is very important. Here is another case. Young girl in the age of 15, 16 had a bleeding where in central surface. And she did a hemiplegic few hours, then improved normal condition. And I always tell to people, we have nowadays three possibilities: endovascular embolization and gamma knife radiation. And see what you like it. And I have this experience and that. So I let free. They went to Stockholm to Dr. Steiner. And then Steiner's concept was correct. He said, what said Dr. YASARGIL? Did he said he can operate? If he said this, we should let operate. So he is expert, he can do it. And then they discussed a little, because such a long AVM needed 2-3 sessions. And the girl decided to come to be operated. 15, 16-year-old. And you see the lesion on surface, and then some 6-7 centimeter long, the longer pyramidal shape, we cut it. And she was intact. It made a very good recovery. You can see on these pictures, MRI and the angiography. Well made it. This is possible. I operated over 500 brain AVMs and some 80 spinal. I had some negative results I will show, but mostly we got it good. 2 gentlemen came from Germany, both medical doctors, and added right-sided, both right-side pareto-occipital AVM. As you can see, on surface they look terrible. But then you have to imagine now with your knowledge in anatomy and then analysis of this 3-dimensional angiography, where you start and how to go. It's a difficult, demanding, challenging surgery, but it needs endurance and discipline. It can be done, as you can see here. He came out without visual field effects, also other doctors. Here. You see the angiograms, it's normal, right and left. Here, where is this? Is a mediobasal temple area, large lesion, and even no straight sinus. And after removal, here another case, 1972, 73, we got a computer tomography. It shows right-sided in the posterior mediobasal temple area lesion. You can see this is parahippocampus going in direction pareto-occipital fissure. young boy. And I said, we have to do this. It's that dangerous. You see, there's no straight sinus. But in these cases, we should operate interhemispheric parieto-occipital approach down to splenium corporis callosum. From there, entering to the malformation. I told already, I operated some 58 cases, and I didn't have any case with visual field defect or hem syndrome. No hemiparesis. It is possible if you run well, but if you go transcerebral from lateral down into the lesion, this can be, you see here, I show you. From lateral, you destroy so many fiber system and cortex, etc. Correct this medial approach. The point is to get the concept. Here, another case, same area, and after removal, here is also very weak straight sinus. And you see here, he sent to me this ping pong picture. He made a very good recovery. Another case, larger in the splenium area. You see here. If you look to the picture first moment, you get shocked. And you say, oh, this is impossible. It's very difficult, dangerous. But studying the picture, three-dimensional, and then you can do it. And to say here, well made it. He's a farmer. Or this case, a little more in the middle field of corpus callosum. Now the corpus callosum becomes from the pericardial artery branches to the cingulate and to the corpus callosum. So an AVM may involve both. And this was well published in a paper of Dr. Ture, the vascularization of this area. You see here how it looks. And here. Here is the patient, and he sent to me the picture. He came from Holland, from Dutch, Netherlands. Another case. Here is involved corpus callosum, mid portion, and then the cingulate. Cingulate has also 4 or 5 sectors. Here it looks terrible. Also from vegetable, and this is postoperative. It's another case, more anterior. It's going down the septal area. After removal, this gentleman came from United States to Zurich. Another case, here more in the septal area, anterior cingulate and corpus callosum. You see how the draining is troubled, straight sinus, and it tries to find collaterals. We have to have an excellent stereoscopic angiography, 4-vessel angiography, to understand the architecture of this malformation. And after removal, another case, Here, where is this? Now, the time is over. Before I started neurosurgery, we diagnosed topographically frontal, temporal, parietal, occipital, or down, We could 1950 some 20 topographic diagnoses. Nowadays, you would not believe me, but we have now, by modern MRI and angiography, super selective, 500 topographic diagnoses. Precise. You can tell there's there. Where is this? If I show this, they say frontal. Yeah. Which frontal? It's the fronto-basal. Caudal fronto-orbital area is here. And after removal, you can see better now. We saved everything. We didn't injure any tissue and vessel. And here, duplicity of the cases, right-sided. We could remove this also well, you see. And this was interesting. As you see, Professor Wallavan came with catheter down there, and then he called me, please, I fear to do anything. I don't like to inject. It's very complicated. You should operate. Okay. And we operated, but you see there are two parts. There is a one caudal fronto-orbital, frontal area, and then a little more middle part, septal area. There. You see here, fronto-orbital and septal area involved. You can see yet now better where it was in the middle picture. Down there, you see how it could be well removed. Now, here I am coming to show you a lesion. Where is this? It's not the front, the parietal or from the temple area. It is in the insula. So we had to make a precise diagnosis. Look here, also here, the trouble with the venous drainage after removal. Here, another posterior part of this is predilection site, posterior insula, retroinsular area. Here, and after removal. Another case. In the volume 4B, I presented this in detail. Here, look here. Another lesion in insula, but straight sinus is stenotic. And after removal, where is this lesion? Where is this lesion? This is a young lady, secretary by a practitioner, medical doctor, had an acute severe headache and became right-sided hemiplegic and aphasic. But interestingly, she improved within a short time and started to speak. She came to Natural Hospital, and the MRI showed the bleeding in the putamen pallidum area, and the angiography showed a complex lesion in the lentiform nucleus, putamen pallidum, and having also feeders from all lenticular straight arteries, not from leptomeningeal, only perforators, but also from Heubner group. And I discussed with her and her mother. Her father was in military service, and she said, I offered, we will discuss this now with the blood gamma knife or embolization, but both have been a little skeptic. They said, we need several sessions, and the embolization very difficult, small arteries. It was interesting. The patient was very clear, and she said, Doctor, I trust you, you will do it. Try it. If I should die, I die in your hands. This is shocking. But we had to wait until father came. He had the permission, etc. It took 3 weeks. Then finally we operated her. It was a long-lasting surgery, several hours. But you see here, clean. Also the lesion there in putamen pallidum area, this was the AVM. It's gone. And now she's a happy lady. She get married, has now children, and she's working in the neurosurgical department as secretary. These are great moments for the surgeon to see such a good result, enjoy with the family, and encourage to do also some more. Then we became a young boy in age from 12, I think, so far I forget him. Where is this lesion? In the center of the brain. And even stenotic situation in straight sinus, it is in thalamus. No, thalamus has also several sectors. I forget to mention brain and spinal cord all together. They have at least 1,000 septal area, segments. We can differentiate and see. And this is now in the posterior part of the thalamus. And we operated. He made a good recovery, but here happened something. I came inter-parietal, inter-hemispheric approach, and they removed the lesion, and it was excellent, and the boy enjoyed. But next day he started to sleep, and the mother gave alarm, said, he's changed. And then we made a CT, MRI. There was an acute hydrocephalus in the temporal horn, because in operated area, the cella media came down and get fixed. And this can happen. And we explored and made free the area because no AVM. And I didn't do anything more, just cleaned. And he recovered excellently. And he later became a captain of a transatlantic ship. So he's doing very well, you see, how the brain is intact. These are experiences. This is another boy. He was a son of a military person in Austria, USA military person. As you see, he has also a complex situation with transverse sinuses in trouble, and the both sides, transverse sigmoid sinus, are in trouble. The lesion, it looks great, not so big in the thalamic area. It's so-called vena-galenic AVM. And we discussed the situation and said we have to do something. And we made it. You see carotid vertebral angiography. And this clip was unnecessary. And I never used any clip by AVM surgery. We coagulate. Here, you see there are 6 types. In the book you have to study this. They are just arteriovenous connections, but we have cases with plexiform lesion also in thalamus and in mesencephalon. This is a medical student came to us to Zurich from Italy. Huge varix. The lesion is not so, but pay attention how large is the venous transmesencephalic veins going through. And we had to be very careful because if we put small temporary clips, but still was still bleeding. So it was an enormous fighting, and we succeeded. As you can see, we made it. And she made an excellent recovery. And she got a dentist. Just, I operated some 80 cases of this cerebral AVM. They came in each area, there are segments. It's a midline, superior part. Oh, this was wrong. It's now a lateral lesion. Again, trouble in the straight sinus. And after removal, I saw 2 disc types, cerebellopontine AVM. And it was very difficult, but in this case, I could manage it. This is the cerebellopontine AVM through foramen Luschke entered in. And after removal, and here the vertebral angiography recovered very well. Here is another case, large lesion in midline, removed well. And this girl here had a only symptom, torticollis, with this lesion. You would think this is impossible. The entire hemisphere is involved. And then straight sinus in trouble, and she developed new collateral venous system. It is after removal. At the time I used clip. It was before CT time, 1968, 69. She made a very good recovery. Now, a table for colleagues, this is in the book, in details, in 3B, I gave precise information, how much problems may arise on what we made by 414 cases, 81. I don't like to say the word excellent. Even myself, I don't feel never myself excellent. Good is good. So the good condition is no neurological mental deficit and working. And this was 81. And then some problems, some seizures by 13%. In poor condition, we have a 3%, but we have some 2.5% mortality. And mainly the problem arises by 16 cases, 16 cases, galenic AVM. I learned if there are plexo AVM, we should not operate because it's in the mesencephalon and in the thalamus area in the encephalon. Maybe young generation, maybe Dr. Ture will go in this field. I lost from 16.5, and you will read in the book the stories. I still suffer about these cases. In spinal cord, look here, large lesion in the vertebral. They look terrible. And I saw only aneurysm arising by spinal AVMs. And I operated some 80 cases, small and large. And can be well removed. And we published together with Lindsay Simon. He died also. And in volume 11, Advanced in Technological Standards, I tell these colleagues they may find more information about. They are not so difficult. They look so very difficult, but we can be dissected. That's it. Professor Krish, this is what I prepared for this lecture, but I would recommend to study volume 3A and B. It's not my work alone. This is our generation work. And I wish I am now 95, and I hope some few years more to prepare the AVM cases from Little Rock on Zurich, or somebody should be behind it. We will discuss this. Good luck of you and all colleagues in the United States. You should be courageous to operate, but you have to prepare yourself in the neuroanatomy, vascular anatomy, and have a good support in neuroradiologists. And very important is to have excellent team in operating room. And these are the operating nurses, and they must be neurosurgical operating scrap nurses. And I don't accept the concept a nurse should be everywhere able. Cardiac surgery, they are expert, but the brain is much important region. And then very important is excellent neuroanesthesiology. They have now better medication, more fantastic control, all these parameters, but they have to stay with the patient. We surgeons, we stay. We don't live to go to smoke or to have a coffee break. They have to stay 3, 4, 5 hours in the room and follow each details, and then it can happen every moment something wrong. So we have to have a good unit, and then good intensive care and the floor nurses. I have been very fortunate to have these conditions in Zurich and Detroit. I hope if you are not well in your team, don't do it. This needs full appraise and full team. I talk too much. Thank you very much.
Thank you, Professor YASARGIL. This was a great moment, great historic really moment with a beautiful review of his experience with arteriovenous malformations. And I think it's well said at the end that having a team approach is very important, because you don't want to be nervous if you have some bleeding that you have the wrong person to help you during the case. And he illustrated all the requirements for that. And again, like he mentioned, it's very important to review his books, both 3A and 3B, because they're not only relevant to AVM surgery, but they're relevant to all types of microsurgery that he does. Again, thanks for everybody. And Dr. Aboud, you mentioned that there's a couple of questions.
Yes, and let me, I'll allow them to speak. Dr. Arturo. You are